Okay, I'm going to begin my exam by assessing the JVP of the patient. I will inspect both sides of the neck, and then I'll have the patient turn their head to the left side. I'll be looking for the area of pulsation less vigorous than the carotid, and it can be suppressed when you put your fingers over the vein above the clavicle. I will use an index card to mark the area of the maximum pulsation, and then I will use a ruler, and I'll put the ruler at the sternal border, and the area where my index card meets the ruler would be my level of JVP. Greater than 3 to 4 centimeters above the sternal margin would indicate hypervolemia, and below the sternal margin would indicate hypovolemia. Next, I will assess the carotid arteries. I will assess both sides, not at the same time, but for the purpose of this exam, I will just show you one side. So I will use my index finger and middle finger to palpate the carotid artery. I will apply pressure until I feel the area of maximum pulsation. And then I will remove my finger until I can assess the amplitude, which is a good indicator of pulse pressure. And then the upstroke and the downstroke can be indicative of S1 and S2. If there was a decrease in upstroke, that could be indicative of aortic stenosis. If there's a bounding pulse, that can be indicative of aortic insufficiency. And then a variation of soft and more bounding pulses could be indicative of ventricular dysfunction. I will then listen to the carotid. If you could please hold your breath. Okay, I would listen on both sides, but what I'm listening for is turbulent flow, which is why I had the patient hold their breath. Turbulent flow could be indicative of atherosclerosis and is an abnormal finding. Next, I will identify landmarks that we'll be using. So we have the aortic region on the second intercostal space on the right sternal border, and then we have the second intercostal space on the left sternal border, which is indicative of the pulmonic area. The mitral area is at the apex, and then we have the tricuspid area, which is at the fourth to fifth intercostal space next to the left sternal margin. I will then palpate the precordium, so I will use the palms of my hands to listen for to feel for heaves and thrills. An abnormal finding would be if my hand was then lifted off the chest. That could be indicative of ventricular dysfunction. And then I will use the palm of my hands to assess for vibrations. This is assessing for thrills, which would be could indicate a valvular dysfunction. And I will palpate the apical pulse, which is around the fourth to fifth intercostal space. And it should be, what I should feel is a light tapping that lasts about 2/3 of systole. And then I will listen to the apical pulse as well as palpate the diameter when the patient is in the left lateral TQ position. I will listen to the heart sounds now. For the purpose of this exam, I will just be showing the spaces I will listen with the diaphragm, but I'll also go through and listen with the bell. So I listen with the diaphragm. I would go through and listen with the bell or apply lighter pressure with this stethoscope so that I could hear the softer pitch sounds heard with the bell. I will then listen at the lower right sternal margin to hear for right-sided murmurs. And I would listen with both the diaphragm and the bell. Finally, I'd have the patient lean forward to bring the heart closer to the chest wall, and I would once again listen to all of those heart regions that I just identified with both the diaphragm and the bell. And then I would finish the exam by having the patient go into the left lateral DQ position, which is the better position to assess the apical pulse. So I would once again palpate the apical pulse in the area that I feel the diameter, which should be around 3 centimeters. And then I also would listen using the bell to listen for an abnormal S3 sound. And that concludes my exam.